We'll just give it 2 more minutes in case other people are joining. All right, so good evening and welcome to this webinar on advancing opportunities for celiac disease clinics and centers, sponsored by Takeda. It will be presented by two teams, the Vanderbilt team with Don Adam, Joanna Perl, Alie Basil, and the Children's National Hospital team, Vahe Badalyan, Shayna Coburn, and Kate Raber. The learning objectives tonight are that this webinar will focus on how celiac disease clinics and centers can improve patient care and increase research engagement by establishing and optimizing multidisciplinary teams to address comprehensive care needs, building partnership with research institutions and industry, and creating opportunities for clinics and centers to participate in research initiatives and clinical trial. There are CMEs available for this activity tonight. If you already have registered with Boston Children's, you can text the code on this slide to the phone number, and it will confirm that you attend the webinar. For first-time user, it's important to create an account. We'll share again that website in the chat, and then with giving your phone number, it will allow you to be registered and have your CME certificate. So tonight we have two amazing teams of speakers. For the Vanderbilt University team, we have Dr. Don Adams, who is an adult GI, director of the Celiac Clinic at Vanderbilt Health, and the medical director for Vanderbilt Center for Human Nutrition. She's also associate professor of medicine at Vanderbilt University. Joanna Perl is a registered dietitian specializing in celiac disease at the Center for Human Nutrition and is also on the Celiac Disease Foundation Dietitian Advisory Council. And Alie Basil is the program manager of the Celiac Clinic and is responsible for patient advocacy, support, and education. On the side of the pediatric GI team, the Children's National team, Vahe Badalyan is a pediatric GI, director of the celiac disease program at Children's Nationals. He is an assistant professor of pediatric at the George Washington University School of Medicine and Health Science. Shayna Coburn is a licensed psychologist at the Division of Gastroenterology, Hepatology, and Nutrition at Children's National Hospital and associate professor of psychiatry and behavioral sciences. She will not be there tonight, but she contributed to the content of the presentation and reviewed the final version. And finally, we have Kate Raber, who is the program coordinator. She co-founded the celiac disease program at Children's Nationals with her parent following her celiac disease diagnosis. Here are the disclosures for Dr. Adams, and then I will stop sharing to allow the presenter to share.
Great, thank you. I think we're going to get started and with how we have built our Vanderbilt program. And I would just like to say that I hope we have some time for questions and answers. I'm going to give an overview of how we've built our program, but I think a lot of this would be helpful to hear questions from the audience, and we can chat about how various institutions do things. Every place is going to be different based on what resources you have access to, but I think there are some common themes that are important that we can review. So this is the kind of the 6 pillars of care that I have focused on building our celiac program. And so we focus on how do we get new patients in, right? So you're building a program, obviously you're going to have to get new patients. And what is that new patient visit going to look like? How are you going to set up this like welcome to your center? And something I really focused on when building our program was making celiac patients feel like they have a home. I know you've all heard this many times, Google gluten-free, not a whole lot of care. And so really setting up that new consult with the expectation that we want to take care of these patients on all different levels. This is what happens at our new visit, and we'll go over that a little bit more later if there's questions. We also emphasize the importance of continuity of care. And what I'd like you guys to notice from this slide is the multidisciplinary approach that is essential to having a celiac center and how we weave that in. So all of our new patients are seen by a physician, and all of our new patients meet with a dietitian, whether they've been gluten-free for 30 years and they themselves are a dietitian, or they never even heard the word gluten until they stepped into our office. We'll also go over how our program manager gets involved in this, but all of our patients are introduced to a program manager at their first visit. For our continuity of care, we have set it up that our patients are primarily cared for by our advanced practice providers due to the availability that they have and the telehealth, and our patients love them because they're just like really accessible for all their problems and issues. We do a lot of telehealth in our center, which has been really, I think, great for celiac disease care and really a big patient satisfaction. We then have them meet with the dietitian and the program manager as needed. Other components of our program, and when you're building a center, include thinking about like what exists outside the clinic, right? And so setting up an easy way to get patients into endoscopy and not just ordering endoscopy, but when we started our center, I met with our pathologists and talked to them about how they're reading their celiac biopsies. And we set up a system that worked with us. I met with a pathologist and said, I want some type of grading, we're using the Marsh score for better or worse, but some type of grading that we can have to keep track of how our patients are doing over time. So we have a protocol set up for any patient that has celiac disease, the number of biopsies they're getting, what pathologists are reading it, and how the output of the path is looking. We've also been able to set up a repository, which if you are setting up a center, even if you're not sure what your research questions are going to be, if you have funding to store tissue, I have found that celiac disease patients are always very open to giving a few extra biopsies during their endoscopy if they think it could be helpful for research. So it's a great way to set up getting that started. Our research enterprise, so kind of spending off of that, I've tried to build this by basically reaching out to other people that maybe are doing things already that could collaborate with what we're doing. So we do have some screeners that we do at baseline, so we could follow patients over time through disease activity indexes, anxiety, impact of gluten-free diet index, and then we also use a restrictive food intake disorder screener as well. All our patients also are screened for food insecurity. And depending on how they answer some of these screeners, we might determine if they qualify for some of our projects, like our telehealth food insecurity, sorry, our telehealth RFID program or our food insecurity study. For clinical trials, so clinical trials I have found are a great way to get involved in the celiac world is to try to get your site in a clinical trial. And so for the clinical trials, I personally talk to the patients in clinic about the study. I don't have my nurse cold call. I introduce them to the concept of clinical trials, and I usually bring it up by just asking, are you interested in learning about research? And we talk about it there and see if there's a trial that might fit for them. Two of our other pillars, patient education. Allie's going to go over that a lot more in what she does, but it's a huge part of our program. And I think it's really important because we're not educating just our patients, we're educating the community. And if you're building a center, that's how you can get more patients in, right? So they find your patient education material, they think it's great, and then they want to come follow in your clinic. On the flip side of that, but similar concept, another way to get patients in is to reach out to the community and actually also within your hospital. I'm going to talk about some programming that we're doing within Vanderbilt to improve patients getting to us. But we also have a large pillar of our plan of our center that is dedicated to going out to primary care, family practice, internists, educating on screening, testing for celiac disease, how to get them to our clinic if they do have celiac disease. Next slide. So this is how we do our long-term care. I wasn't sure how much we wanted to talk about that in this webinar, but I know everyone has slightly different approaches, but I think people have a overall similar concept at the celiac centers. But just noticing there's different points where they're touch basing with dietitian, with physician, with mental health provider, and then weaving in their lab work and their imaging and endoscopy when needed. A big part of our clinic, like I mentioned before, is to stress the importance of continuity of care and to really make our patients feel like they should come back and they have a home. Okay, next slide. And before the more important people on my team start talking, which is really what I think draws in our patients, I just wanted to introduce two things that we have done at Vanderbilt. Big academic center, like I'm sure many people that are listening. And, just to get it out there that you even have a celiac center and also to get patients in quickly and improve diagnosis. So one of the first things we did was on the lab, we added some verbiage about interpreting the you might want to consult the adult celiac clinic. And so if anyone orders a celiac antibody, they get a report suggesting that they consult the clinic. Another and so far, it's only been going for under a year, but really helpful is an e-consult service. And so this is a service where a physician, if they have any kind of question about a celiac lab, or they have a patient, the question about does this patient have celiac or gluten-free, they essentially put in an e-consult and it comes directly to the celiac clinicians in our e-basket. And basically, they filled out this form, as you can see here. They have to like, what is the clinical concern? Is the patient already gluten-free? And it imports the lab. So, this patient obviously has very high celiac serology. So this came to me. And so then I can immediately reach out to the patient and introduce the concept of like, do you want to talk about non-biopsy diagnosis? A lot of patients are like, I just want a biopsy anyways, right? All these nuances, or like, you just have celiac disease, let's get you in clinic. And so this has really improved our ability to get patients in quickly, either to endoscopy or clinic, depending upon what the question is and what our next plan is. Okay, so I'm going to pass it on to the two other really important people of my team that I think really are what, oh, actually, never mind. I have one more slide. So I started the clinic 10 years ago and it was just me and a dietitian. There we are. There's us. And it wasn't Joanna, so we couldn't put Joanna's picture in. We had to use a cardstock dietitian here. And then over the past 10 years, we have grown very large. And I think a lot of this has been through just networking, just like finding out what other people in my institution were doing. Functional medicine already had a program for IBS, and we thought, wow, it'd be really great to have a program for celiac disease. And in psychology, I read an abstract about ARFID and IBS, and I thought, oh, this would be really great to have someone working on this in celiac disease. And so reached out to people that were already doing some of these teams. Our translational research program has only really grown over the past year, and that is really due to a very generous philanthropic gift we received essentially to build research at Vanderbilt in translational and basic science. And so we were really lucky to receive that. And because I had that money, again, just reaching out to people that already existed at Vanderbilt, doing things that could possibly translate to celiac disease. And so these are people that were already well established and now are excited and part of our celiac team. Okay, so now I'm going to hand it over to, oh no, I'm not. I'm still not handing it over. This is horrible. Okay, this is some things that we think are great about our clinic. And just briefly want to talk a little bit about the struggles and wish list that you might see here. I think this is a lot of things that people would apply to any institution and things that you have to deal with, just like how do you get patients in quickly? How do you get your records? How do you deal with insurance problems? Like we want to take care of all celiac patients, but we can't see all of them because of insurance. Hospital bureaucracy, setting up interdisciplinary collaboration, just getting all these things set up are things that we have like struggled with and are working on and trying to get better. Some of these things we have improved upon. I think, like, for example, all of our patients are able to see a dietitian, which is really great. And Joanna's going to talk a little bit more about that. We have a great team that, although we have a little bit of remote work, a lot of us are on site together all the time. And so I see a patient, I go in, I talk to Joanna directly, and we have like a great team handoff for our patients. So really, really great. So I don't want to dive too far into this and take up too much time. So I think now I finally can hand it over. Is that right? I'm not driving the slides, so
Yeah.
okay, yes.
As Dr. Adams just kind of started to mention, the RD role very much starts kind of at that first, with every new patient. Other Dr. Adams or any one of the providers will come into the dietitian office and give an overview of kind of where this person is at, whether they haven't been diagnosed, in which case we're going in to go over what the gluten challenge looks like, or assessing if they are getting enough gluten to be diagnosed further, or if they've decided to not do a diagnosis and we have some sort of suspect, like we think it could be celiac, we can sort of give loose teachings at that point. Or if it's at their diagnosis or they're a new patient to us who have been gluten-free, like Dr. Ab said, for 30 years, we're still going to do a kind of initial assessment of their education and give anywhere from a really new teach to kind of checking through and making sure they have no crazy myths that they've read on the internet, or, they're not over restricting, which is a lot of what we see, or people who, they come in, they're very gluten-free, but they also don't ever leave the house. So, kind of assessing where they are in that journey. And then post-diagnosis, if they've been a patient of ours for a while, it's largely based on whether the provider thinks more follow-up is necessary. They're either still getting gluten, or they have other nutritional needs or other dietary triggers, or if the patient requests it to kind of like they have follow-up questions, they're going on vacation, they have Thanksgiving with their in-laws for the first time, all of those kinds of things. So we may see them, we always see them at a first appointment. We may see them at follow-ups after that. And then, okay, next slide. So then our kind of like, after we actually see them in clinic, we continue to kind of have a role in the flow, both through messaging the patients directly after appointments, or if they have follow-up questions. We always tell patients, we're an ongoing service. So, the sort of initial appointment that they may have follow-up questions on what's this ingredient, anything like that. And we kind of let them just message at will, which is great because like we're not a billed service. So this prevents having to do like an appointment for just a random one-off question too. And we can kind of get through we can do that really fast and give them really fast follow-up information. We also will do a lot of the messaging around lab results, if it's vitamin recommendations, mineral recommendations, things like that. Or if it's like your celiac records are still very high, we need to meet again and do a follow-up. So we may actually end up scheduling our own follow-ups as well, in addition to kind of what's going on in clinic. So if that might be because they needed additional education before their next follow-up appointment, other kind of like lab result issues that we want to kind of review with them. Sometimes we've initiated a trial run of something, whether it was like a no oats or something like that we've sort of initiated with them, and we want to do a follow-up before they're going to see the provider to kind of review that. So we schedule that directly with them through messaging, and then ask our scheduling team to put that in. I'll just point out that is something that I think is easier for our team, because I work with 2 other dietitians, 1.5 of us who are very specifically celiac based. So if we were trying to manage being present in clinic and also scheduling our own appointments, you would find more challenges probably trying to like navigate that. As it stands, we have kind of windows where we can sort of blocks of time where clinic is slower for us, or we can sort of triage the patients with the other dietitians. And then the last thing is that we're kind of a communication hub between some of the things that Dr. Adams had mentioned, like if they have screened positive for ARFID, if they are seemingly they screen positive for food insecurity, we can sort of give that to the correct person who comes after that, whether that's Alie or our ARFID team. With all the new patients, we will also forward them to Alie to kind of do follow-up outreach with them. So that is coming through us. And then also kind of back to the providers, if there are other questions that we sort of gauged from our follow-ups that are outside of our scope, or if they're eligible for studies that the providers are really going to be bringing up in their own session. So there's this very like constant flow of information, and the RDs tend to kind of be a little bit of the hub to the various different like spokes of that. And that's, you know, the overview of the role. And so yeah, I'll give it over to Alie from there as far as like what her then, because I sort of pass it on to her at that point.
Okay. So also I just want to apologize because I'm sharing on like for you all to see on a screen that's to my right, but my camera's to my left. And I'm worried if I like switch it, you all will not be seeing the right thing. So if it looks like I'm not looking at you, that's why. Um, so we have kind of had an interesting case study with having me, the program manager, in the clinic and virtual. So I can kind of share a little bit on both ways that we've done things. So the first several years, I was in the clinic, and so I would physically meet all of the patients, new patients, at the time of their first appointment after they met with the dietitian. And at that time, I would have a conversation with them about any non medical needs that they have, any accommodations that they need. A lot of the patients were either, who did need accommodations, were either university students, they were traveling a lot, or like government employees, things like that. Um, and then I would also give them a welcome packet that included like all sorts of different information and gluten-free snacks and other kind of like lists of gluten-free items and magnets and all sorts of stuff. So we still give them their welcome bag I believe, Joanna, you give it to them, right? Yes. Okay. So they're
Yeah,
getting it
sorry.
from Joanna. Now I am completely remote. So what our flow has become is basically after a new patient is seen, I'll get a message in Epic from usually the dietitian, occasionally from the clinician, that will give me context as well as their MARSH score. So we're keeping track of everybody's baseline MARSH scores and lab results. And so I'll then know, like, okay, we have a new patient. So I'll reach out. This is an example of a new patient message, which I'm realizing you can't really read it, but basically introducing myself. I include a ton of resources in there and links to different things. We have a local support group that we sponsor in the Nashville area, so I include information on that, and then I also provide how they can reach me if they'd like to set up a consult. So from there, the patients can schedule time for a virtual consult with me. Usually, the patients that do want to meet with me are the ones who need like special help with certain accommodations. So it's like typically, again, like the college students or people who are traveling all the time and want help navigating that. So that's kind of our general new patient flow. If there's a follow up patient that needs something, so typically that is a patient who is either food insecure, a patient who needs an accommodation letter, or a patient who's just not really doing well and needs some extra resources. So typically that would be I'm connecting them with the support group. We have actually three different ones. One is like a general support group, one is specifically for young adults, and then one is for parents of celiac kids. So I kind of help like direct them and connect them to the right people. And then I'm just going to share a little bit of some programming and engagement that we do that I think is really valuable, both from the perspective of raising awareness for the clinic in the community as well as within GI and family medicine, but also just like extremely powerful for patients. So myself, Dr. Adams, Joanna, and another one of our colleagues actually published recently a review about using technology to educate patients with celiac disease. And it is just such an incredibly powerful tool because so many people do not have access to credible resources and education. And so we've really tried to lean on Instagram. And honestly, the reason we use Instagram is that's what Vanderbilt has approved us for. I think there's probably other platforms that are great too, but we use Instagram to pretty consistently be posting content that is going to be credible, accurate, answer questions, kind of address a lot of the education type content that a celiac patient really, really needs that they may otherwise not have access to, or have quick access to. So these are just some examples of the type of content that we post. Obviously, depending on like the season, things are different. um, but we do try to post like very regularly. We also do a good amount of virtual education where we try to partner with experts from within the field. I've worked with a lot of, or we've worked with a lot of SSCD members on this to try to bring new and fresh content. It's also like really, really great for making connections within the celiac space, doing this type of virtual education. So we always love to do that and learn about what other clinics are doing. And then we also do in-person education. So just the one that I put up here was a really cool event we did at a distillery, but we do all sorts of things to try to bring people together and provide education on a topic that might be kind of controversial or confusing. So like, for example, whiskey. A lot of celiac patients don't understand the nuances of liquor and whiskey and all of that. So that was a really fun one. Patient support and community engagement obviously is always incredible to do. So we try to do as many just fun patient events as we can. We do a lot on campuses, so we work closely with the local campuses in the Nashville area to try to make sure that their students know that we exist. I think it's been really fruitful. There's always patients that come by from the various universities that didn't know about us that want to be followed while they're at college for 4 years. And then we also, try to do all sorts of things. We did like a really fun workout class. We did, we do our gala, all sorts of things. And who we are serving ice cream at our gluten-free ice cream party last summer. And then the last thing I'm going to talk about is just clinician outreach. I think that this is really important for growing engagement in your clinic. Obviously, there's so many patients out there that are going to their general practitioner first for screening and diagnosis, and we want to make sure that family medicine doctors know how to diagnose celiac disease. So one of the things that we work on a lot at our clinic is physician outreach. So we do a lot of like in the community events. We go to like family medicine conferences. We also have had search engine campaigns targeted for family medicine practitioners. We have brochures that we get into family medicine practices, and then our providers are talking at all the conferences that will take us on celiac disease. So just kind of food for thought, not to forget about other clinicians when you're thinking about encouraging engagement. So that's it from us. Are we gonna do questions now or wait till the very end?
I think it would be best to wait at the end. Thank you so much for sharing your experience. You all built an amazing program. And now we're gonna switch gears to the National Children team and then do questions. All right. Nope, I don't think that's what I want. Okay. I don't think I need to.
Okay, do you see those correctly?
Yes.
Okay, great. So hi everyone, thank you so much for joining us. My name is Kate Raber, and I'm the program coordinator for the celiac disease program at Children's National Hospital in Washington, D.C. And also with me tonight is Dr. Vahe Badalyan, who's our medical director. So we're going to split this presentation into two parts. So first we'll tell you the story of our program's creation and its evolution into what it is today. And then we'll hopefully give you a roadmap for success for either setting up your own program or bolstering your program using the lessons that we've learned over the years. And as a heads up, I am a millennial for better or worse, so I'm going to be using some millennial communication tactics throughout the presentation. Now, as we start, I do want to take a quick moment to acknowledge Dr. John Snyder, who was our program's first medical director. He's a big reason of why we are where we are today. And sadly, he passed away almost 10 years ago now, but we know he'd be very proud of where we are today. And this is where we are today, a robust, internationally recognized pediatric celiac program in the nation's capital. And we'll go through the details of what our clinic looks like in a little bit here, but let's start at the beginning of the program. Now, every hospital program starts with a need. So for us, that became clear in 2006 when I was extremely sick on a family trip. This is my family on New Year's Eve of 2006, and I'm on the right attempting to look like I was having a good time. Now, soon after we got back, I was finally diagnosed with celiac disease at Children's National after 14 years of symptoms. We were told that the treatment was a gluten-free diet and to come back in 6 months for a follow-up appointment. We were so relieved that we finally had an answer, but what were we supposed to do now? What even is gluten and how do we get it out of my diet? We were honestly completely unsupported in this process. And so once we started to figure it out, my family became determined to make sure that nobody else went through that same experience we did. So my mom reached out to Dr. Snyder, at that point, the chief of GI. And before her first meeting with him, my mom sat in her car and created her pipe dream for what a program would look like if she could do everything that she wanted. Now, this five-pronged approach to celiac disease that she came up with became our program's mission statement. So we want to provide state-of-the-art care for our patients using the most up-to-date knowledge and screening practices around. We wanted to ensure that we met the psychological needs of our patients. And this is one of the biggest must-haves for our program because both my mom and I experienced many difficult and conflicting emotions after diagnosis, again, having nowhere to turn to deal with them. We wanted to make sure that we were educating local pediatricians and specialists so that they could also screen for celiac disease. My pediatrician had told us that I was never screened for celiac despite all of my GI symptoms because I was always in the 99th percentile for height. So it was time to dismantle that old school view of celiac disease as a disease that only involves failure to thrive. We also wanted community outreach and advocacy. It was so important to make sure that we could take care of our community. Now, at the beginning of the program, we offered things like grocery shopping trips, cooking classes, and education expos to increase local awareness and education about celiac. And lastly, we wanted to contribute to research. We knew that more knowledge about this disease wouldn't come just with clinical care, so one of our goals was to contribute to the well-being of patients through research. Now, needless to say, that meeting with Dr. Snyder went well, and my mom describes this program as starting with an idea and a handshake. But the next step, though, was money to start, because at the beginning, our program was almost entirely funded by philanthropy. Now, I'm not going to get into the ins and outs of what we did to fundraise, but needless to say, it was definitely a full-time job plus overtime with all sorts of events, reaching out to companies and reaching out to people in the DC area to try to start this program. Now, we eventually launched an ad hoc celiac clinic with medical providers. So we had MD and NP, a dietitian, education specialist, and importantly, a psychologist dedicated solely to celiac patients, which was the first of its kind in a pediatric celiac clinic in the US. Now, interestingly, at that time, the hospital did not believe that celiac disease was a reimbursable condition for a psychologist. Now, because of this, philanthropy paid for a psychologist for many years until the hospital felt that we could prove that insurance would, in fact, reimburse for this. We also got heavily involved in our community through many different avenues that you see on the screen there. And we also attended conferences and later presented at conferences. So this was phenomenal for networking purposes, but it was also really good for just learning about celiac disease itself and making sure we were holding ourselves to a high standard of care. And so in 2017, we received a large donation to begin a more solidified multidisciplinary clinic with some added disciplines for a study. So this clinic met twice a month for a one-stop shop, and we had 6 different disciplines involved. We had gastro, a dietitian, psychology, education, and a neurologist and neuropsychologist who were part of a 3-year grant, essentially, to study the neurological and neuropsychological effects of celiac disease. For those first 3 years as well, we did not have a dedicated coordinator. So we had people who sort of stood in as coordinators, which that coordinator changed many times over the first couple of years. Now, this multidisciplinary clinic still stands today, and this is a sort of snapshot of our clinic today. It's similar to the one that we started in 2017, although we don't have neurology and neuropsych. So all of our patients have access to a GI provider, a dietitian, a psychologist, an education specialist, and then a care coordinator. So let's talk a little bit about what this process looks like for our patients. Now, once the diagnosis is received, referrals are placed for celiac education and for a multidisciplinary clinic appointment. Now, I typically receive that information on the referral and then send educational materials to the family to bridge that gap between when they receive their diagnosis and when they get their gluten-free diet education. We have, in those resources, we have the robust library of handouts and other resources that our patients are sent and that they have access to on our website. And so we've made sure that all of these resources are free of charge to our patients and free of charge to the general public. And so all of these handouts and other resources can be found on our website. Now, ideally, we have this education appointment before the multidisciplinary clinic. And this is a monthly group education class hosted by myself and our dietitian, where we go over the ins and outs of celiac disease and the gluten-free diet and what to expect next. We hold it over Zoom for the sake of convenience, and it lasts about an hour and a half, and we've gotten really good feedback about it. Now, after this education session, the family then comes for their initial multidisciplinary clinic visit. At this visit, they meet with a member of our GI team, so either Dr. Badalyan or our nurse practitioner, Lori Stern. They meet with a psychologist, Dr. Shana Coburn, and then they also meet with myself to do a check-in and see how things have been going. It's still a one-stop shop, and we do try to keep our consults to 30 minutes, and keyword is try to keep it to 30 minutes. So after this initial visit, they will then come again to see us in 3 or 4 months after that. And we ask them to get blood work done prior to that appointment so that we can review it with them at the appointment itself. Now, at this follow-up, we have our patients visit again with a member of our GI team and then with our dietitian as well. And of course, they can always add on psych or education if they feel they need it or want it. But we decided to do it this way because when we first started this clinic, we received some feedback that talking about both establishing a gluten-free diet and how to keep that gluten-free diet balanced was really overwhelming. And so we sort of kept the two separated and try to get our kiddos on the diet first, and then we tinker with what it looks like from a dietitian perspective. For most patients, after that first follow-up visit, we'll see them again at the 1-year mark and then just annually afterwards. I like to describe our clinic as sort of a choose-your-own-adventure clinic because they can opt for care only with our GI team, so either Dr. Badalyan or our nurse practitioner, or they can come to the multidisciplinary clinic and within the clinic see as many or as few of the disciplines as they'd like. So I speak with the patients in advance of the appointment to get them lab forms, as well as checking to see which disciplines they'd like to visit with, and then on the back end, create a template so that we can keep ourselves organized during clinic itself. Now, when COVID hit, we had a fast movement to telemedicine, and I'm sure all of you probably experienced the same thing. And for us, telemedicine was a resounding success. We did some QI projects to look at people's satisfaction with it, and people were really happy with being able to get follow-up care and diagnostic care, for that matter, via telemedicine. And so it was actually so successful that we are now still about 50-50 telemedicine and in-person for appointments. So this allows for a really large catchment area. Of course, we have our patients in DC, Maryland, and Virginia, but we also have some patients in Pennsylvania, West Virginia, and Delaware. Now, of course, with telemedicine laws having changed, these patients do have to drive over the border into Virginia or Maryland, but it's allowed for a much better access for all of our patients who choose to use it. Now, the other sort of silver lining that came to COVID, in addition to telemedicine, was our full financial integration into the hospital. Previously, we had been mostly based on philanthropy, and the process had already started, but I think this escalation into being integrated financially into the hospital can be partially attributed to COVID, because philanthropy dried up everywhere. I think every hospital in the US probably saw this absolutely exponential drop in the amount of donations, and particularly large donations that were more routine pre-COVID. So at this point, it was a natural segue into our program becoming fully embedded, which meant that nobody's salary was dependent on how much money we made that year. So that provided us with a financial stability from a salary standpoint that really hadn't existed before. And so the reality, though, with that is that we did have to scale down certain things once that philanthropy dried up. And so philanthropy, while it's wonderful and it has its place, is likely not a long-term option. And so this is why it's just important to work within your system where you can. And this is just a little shout out to my fur nephew, Shrimp, who's clearly no longer worried about fundraising. So now networking. Now this is, was and remains a really important part of our program. And so I think if you are looking to craft a mission statement or really reinforce certain things in your existing program, that networking and collaboration should really be a part of that. Now, of course, we have our collaborations within Children's National. I would say that one of our first sort of allies that we had was our endocrinology and diabetes team. They were so helpful because their program was much more established than ours, and it also had a similar care model. Of course, we have our collaboration with lab medicine and pathology, and not just for endoscopies and lab work, but we also have a biorepository. So we do have some freezer space where we keep tissue samples. We have our neuro and neuropsych colleagues. We still work with them from time to time and refer back and forth between our departments. And then lastly, a really cool thing that's available in the DC area is something called the Pediatric Health Network. And this is a network of a couple thousand pediatricians in DC, Maryland, and Virginia. It's sort of an organization like AAP, but a bit more on a regional scale. And we've collaborated with them for CME activities, conferences, and for studies. So the opportunities with a partnership like this are really endless. And then we have collaborations outside of Children's National. And these are also really vital and hit on several areas of our mission statement. So we have Raise Celiac, which we also call Celiac Kids, which is a group of pediatric celiac programs around the country that we collaborate with on research. It's also a great group where we can send an email and say, hey, we have this tricky kid. What would you all do in this situation? Or, hey, this is what we've been doing in our clinic. What are you all doing? And getting ideas from each other. There is a celiac SIG at NASPGHAN as well, which has really grown over the last few years. Obviously, we have the Society for the Study of Celiac Disease, recently absorbed by the Celiac Disease Foundation. And SSCD includes adults, and they hold great webinars like this one, and craft position statements and do all sorts of really important things for this community. Now, if you join SSCD, you also get membership into ISSCD, which is the international version of SSCD. And this is the group that works on all sorts of international initiatives, but it also holds the International Celiac Disease Symposium, which is held every other year in different cities around the world. It's like 2.5 or 3 days of hyper focus on everything there is to know about celiac. So I believe in like a year from today, we're going to be in Melbourne, Australia. And then 2 years after that, we'll be in Tampere, Finland. And of course, we would also be remiss if we didn't mention the advocacy organizations. So we have Celiac Disease Foundation, Beyond Celiac, National Celiac Association, and Gluten Intolerance Group. These are all national groups that help us with patient advocacy and research. So they're excellent partners to have for many reasons. And lastly, we partnered for a time with a local DC organization called Food and Friends, which is an organization that provides medically necessary food for families in the area with food insecurity. Now, though, we actually send our food insecure families to the Celiac Disease Foundation to participate in the Celiac Disease Food Insecurity Research Network. So let's go through a roadmap to success based on some of the lessons that we've learned over the last 15, 17 years or so. So I think the first step in the creation of any celiac program is creating a mission statement. We would recommend keeping your mission statement broad. Obviously, you don't know what you don't know, but it's a great idea to try to think ahead to what you might want to cover at some point. Review your mission statement periodically, even if you've been established for several decades. Make sure it's still relevant and that you're actually following it. It's okay to expand that mission statement, but it is helpful to have a well-rounded mission statement from the start, even if you have to tackle it in sections and prioritize things over each other. I think most importantly, though, a well-written mission statement creates a sort of central document around which you can plan and grow your program. So it's not uncommon for there to be a lot of people coming in and out of your program, and that's particularly the case in development offices at hospitals. So when you have a lot of people with a lot of ideas, it's really lovely, but sometimes that mission can get lost. And so it gives you this sort of guiding light, and it also helps from something I think all of us are probably guilty of at some point, is going down intriguing rabbit holes, but rabbit holes nonetheless, and making sure we just stay focused. We recommend finding an ally who believes in the cause with you. Throughout this whole process of starting this program and continuing to run it, we found a few allies. My parents allied with me in order to try to make the celiac community in DC and beyond a better place. My mom found Dr. Snyder and Vanessa Weisbrod, who also believed in the cause and who were willing to roll their sleeves up and get the job done. And now we have allies not only around the country, but all around the world who work with us. I think another important thing to do is speak with your stakeholders directly. What do patients actually want? I think a great example of this would be if you want to have a large presence in the clinical trial sphere, but your hospital is in a food desert, or it serves a lot of patients who live in food deserts or in a lower socioeconomic area, there might be a lot of food insecurity in your population. So none of your patients are going to want to sign up for clinical trials if they can't feed themselves or feed their kids. So check in with the community that you serve so that you can find a balance between what's important for the greater good of celiac, but also making sure that you're taking care of the people around you in a way that works for them. Find your quarterback. There are a lot of people who will be there at the start or just at any point throughout having a program who are going to have a lot of ideas, but who's actually pulling things together? Who's executing the vision? At a minimum, I think it's required to have a coordinator or a manager, so a professional cat herder, so to speak. We were so incredibly lucky that we had Vanessa Weisbrod as our quarterback for over a decade, and her dedication and skill was vital to the success of this program. So having somebody who's dedicated both literally and figuratively to a program makes all the difference. It can be sometimes hard to have funding just for one person dedicated to a very small program. But if you have a person who's pulled in a lot of different directions, their impact may not be as large or meaningful. And so this is a really good area where philanthropy might be helpful to sort of buy out the rest of that time. Thinking outside of the box and normal hospital procedures may be necessary. And I think this is actually a big part of why we've been successful, is because for a long time, we had to think outside of the box in order to get anything done. But also remember to think inside the box. Don't reinvent the wheel. What's already available to other programs? Reach out to these programs and find out what makes them tick. I think a great example of this is we as a program spend $0 a year on marketing because we have an excellent marketing department that we can just send them an email and ask them to figure it out for us. Prepare for unpaid physical and emotional labor. There were several nights before galas or before gluten-free expos where we would be up until the wee hours of the evening drinking wine and packing goodie bags for attendees, making table decorations, or making last-minute tweaks to seating assignments. Volunteers are a great source of help in situations like this, but remember that most volunteers don't have access to hospital systems, and they often aren't as familiar as you with how things need to work. So it still does require a decent amount of work on your end. Next, make sure to spread your message and continue to keep spreading it. Getting the community involved is so vital to the success of a celiac program. In our case, we started with school nurses, local pediatricians, we developed CMEs, we hosted community events, and again, we have utilized hospital marketing. If people don't know that you have a program, they're not going to come and see you. And again, philanthropy is important, but it's extra important to navigate it successfully. If it's done correctly, it can provide you with some freedom to do certain things that you want to do, but it's important to make sure that there's a balance between donor wishes and feasibility. And so, for example, if you get a grant or a donation to do something, and this is going to seem really simple and like a no-duh, Kate situation, but make sure what's expected of you is actually feasible. Do you have enough staffing to do it? Is this a scientifically sound venture, or are we just throwing money at something and seeing where it sticks? Do you actually have goals or objectives that you want to accomplish? Is it done in an organized way where things are going to be collected in the same manner throughout the course of a study? So the importance of making sure that things are set up in a way where it will actually pay off later down the road cannot be understated. And I think that's a great place for your development office to come in and work with that donor to try to make it as unrestricted as possible. And lastly, networking and collaboration is so important in any celiac program. And I think that reaching out to colleagues and collaborators if you're stuck or if you have a great idea is one of the best things that you can do. Because remember, we're all on the same team and we all want to see each other succeed in this. And so thank you all so much for joining us tonight. These are all of the amazing people in our celiac program, and we're so thrilled that we had the chance to share our program with you tonight.
Thank you so much, Kate, and thank you to the Vanderbilt University team also. So we will now take questions. So I invite you to either raise your hand, speak up, or write in the chat if you want to interact with the presenters.
So if I can start a question. I think you guys have done an awesome job, both the teams. I'm going to start with the Vanderbilt team. So Dr. Adams and your team. You talked about a celiac multidiscipline clinic. How do you populate that clinic? So you get a patient, they get diagnosed, and how often do you have this multidiscipline clinic? Who's the person who populates that clinic? Kate mentioned what she does in DC, but how does the Vanderbilt group do it?
Great question. So our multidisciplinary clinic right now is mostly at the same day consisting of the clinician, dietitian, and program manager. We do work with functional medicine in our psychology program, but those are set up on a separate session. So we just reach out to them, and a lot of those programmings are done over teletherapy. So that's really at the patient's convenience. I have yet to be able to set up a clinic where our bone disease doctor is there, or a neurologist, or a hematologist. And I think it would just be really difficult because not all the patients have the same symptomatology and need the same things. And so I think we've really focused on the sort of the symptomatic, functional, and psychologic side of creating that clinic.
And how often does your team meet? So if a patient gets diagnosed on a Monday, how do they come to that clinic?
If they're diagnosed on a Monday, that's a great.
I'm
They
just
first have
giving
to
an
get into
example.
our
So,
clinic.
somebody gets diagnosed,
Yes.
gets the call to make an appointment there.
Yeah, so if they're diagnosed internally, usually what happens is we're getting a message from one of our colleagues and we're getting them in pretty quickly. That e-consult service we started has actually really helped to get patients in quickly because that allows me as the clinician to like quickly review the records. And then if I can't get them in quickly, I can usually get them in with one of my APPs within 1 to 2 weeks if I feel like it is a slam dunk, like this is obviously celiac disease. And we can get them seen quickly by an advanced practice provider and a dietitian. But
And
if you go through the traditional sense of like waiting for the consult to get scheduled, man, that's months. And that's exactly what we are trying to fix, but we're still kind of stuck on that long wait time for a traditional just consult coming in, referral from a community doctor with no kind of information or communication.
thank you.
So there were a few questions in the chat. So Rachel Lieberman is asking, is there a pediatric arm at Vanderbilt University?
Yeah, I was actually
Yes.
able to
Okay.
type a response. Yes, so there is a pediatric arm. They have a division in the Children's Hospital, which is physically just across the street from us, and we do work very closely with them. So, from a programming perspective, almost everything that we do extends to the Peds Clinic. So, all of our events, all of our virtual education, we try to incorporate at least a third of it for the peds families, and then we do also have a specific support group for the parents of celiac disease kids. They do also have their own like educational consults that they do, but most of the programming is joint. And then I don't know if Dawn, you want to speak more to our like transition of care process.
Sure. Yeah, we start seeing patients anywhere like transitioning from peds to adults, anywhere from 17 to 21. We do kind of try to get them a little bit earlier if we can because Alie is a little bit more in our clinic than in the peds clinic, and so we can help with like the college and the transition. But that process seems pretty smooth. We just have a referral over and we get them seen um, when they need it.
Great. And Telly Chung is asking, how does your center navigate follow-up management with other GI physicians in your practice that may also diagnose celiac disease? Like, are all the cases going ultimately to your programs, or are celiac disease still managed like independently as well?
I can speak for our program. We try to get them all to eventually come to us, and we a little bit control that by they only can meet with our dietitian if they see one of our celiac providers. I have a lot of reasoning behind that that I can talk about in more detail at another time, but I'll also let Vahe comment on how they do it.
Yeah, ours is also fairly easy. We have about 20 GI providers between physicians and nurse practitioners, and being sort of a small facility, freestanding children's hospital, everybody knows us. So if there's any kind of question about possible celiac or newly diagnosed celiac, they usually refer to us. And we also have reporting systems where I run those reports from time to time just to query all the patients that have celiac diagnosis code, and then we sort of check to see have we seen these patients in the clinic already? Have we touched them, or we haven't? We don't know these patients. So if we don't know these patients, we reach out to the providers and kind of see what can we do. We also have I sort of gradually transitioned my clinic slot types from, let's say, general GI or other types of GI slots to celiac slots. So when the patients contact the call center and there's a concern about celiac, I'm the only one really that automatically has those slots. So they probably like 90% or more patients end up coming to see me or our nurse practitioner. So that helps kind of funnel majority of patients to us.
Yeah, I'll
Yeah.
also add we have a similar decision tree with our call center. So if the patient is coming in specifically for celiac, they get funneled to our clinic, just as Vahe mentioned. Sometimes when they're not getting diagnosed until they're in general GI, and then they will come over to us after diagnosis.
But then, Dr. Adams, you mentioned that every patient that comes in gets a dietitian to see them?
Mhm.
If they're just coming in into your slot, is the dietitian just there on standby so that if a
Mhm.
patient comes in, so then she will
Yeah,
just.
that's the way we do it. I know everyone does a little bit different, but we essentially don't have the dietitian scheduled visits. They're kind of just there and ready to see whomever. So some days, every single one of my patients they have to see, and they're very busy, and some days they don't really see a lot and they work on other things. So it has been, I've really liked that flexibility, and Joanna might be able to comment as well.
Well, and I will say, just because with the other follow-ups that we're tend to be scheduling, it's usually like we're all busy on something, but there's always one of us who is free to see an incoming patient. There may be the occasional time where we're on telehealth with different providers, or we can't get on a telehealth with someone because we're in the rooms, in which case we'll do a pretty fast follow-up. Like we'll either call them that same day and set up a telehealth same day, or later that week. So we have good flexibility to kind of get people in pretty fast.
And does the DC group have the same flexibility with the dietitians?
Yeah, we do. They, we're all very closely, close-knit group, so it usually is not a problem to get a dietitian to assist the family multiple ways, in-person visits, telehealth visits, messaging through the chart, sending some materials. So whatever the patient needs, really.
And do your dietitians, I heard that Dawn doesn't allow the dietitian to see anyone, but how about at DC? Do the dietitians see other patients, or you have exclusive rights over the dietitians as well?
So far, I think that they see other patients as well. But I don't believe right now it's sort of compromising their ability to see the celiac patients.
And my last question on the dietitian, and then I'll be quiet. Who pays for the dietitian's time?
Meaning GI or other services? In our case, nutrition pays the dietitian's time.
So the division does not have to pay for the dietitian's time, and the dietitian just is paid out of the goodness of the nutrition group's heart?
Yeah, because they're also seeing other types of patients.
Amazing. And on your group?
Our dietitians are paid from the GI division.
And you're not billing the patients?
We're not. I went through this kind of maybe a year and a half ago, 2 years ago, and when you actually look at how much money the dietitian can eventually bring in, it's very little, and it's a lot of paperwork. So they kind of gave up on it a while, especially when the dietitians weren't able to do telehealth for a short period of time. I can't remember if that was a regional Tennessee thing or a national thing. But I have a feeling my institution's going to bring it up again at some point. But when I started, that was part of the negotiation, was that I wanted a dietitian that wasn't billing. So somehow we're still moving along. We have three outpatient clinic dietitians in our group, but they're not all celiac. We also do intestinal failure and other things as well.
Fantastic. Thank you.
Yeah, so thank you for clarifying how your schedule can be flexible to accommodate the patients. But for people who are starting like a celiac center and want to block their time to see celiac patients, how long has it been until you got full clinics with patients? Like Dawn, you mentioned that you started 10 years ago with a dietitian. So how long would it take to kind of have a running clinic?
I think that depends on all the things that like we talked about, especially Kate too, like outreach and awareness that you're here. And I think it's impractical to think you're only going to see celiac disease patients. At least I feel that way as a gastroenterologist. You're going to end up seeing different kinds of patients. And I'll have some clinics where I seriously only see celiac the entire day, and then I'll have another clinic and I didn't see a single one. So I want to say it took me a good 5 years to really feel like I was seeing celiac patients regularly, and that's building from scratch, like from zero. And once we had a program manager, though, that was really getting our name out there, then our consults went up significantly, and we're a lot more full with celiac disease.
Could I ask a question?
Of course.
Well, firstly, I can't miss this opportunity to congratulate Kate and you, Vahe. That was a fabulous presentation. It's been a long time since I've had a chance to see you, and I don't see Vanessa, and I miss her enormously. One of the things you haven't said is what a pleasure it is to be part of a team like this. I'm retired now, and I have to tell you, being part of that kind of team and that coordination and that friendship and that stimulation is something I will miss till my dying day. And maybe it's not the right place to say it, but I can't resist telling you how grateful I am for what you provided to me. Vanessa, what an amazing woman you are. I met Kate's mother at a place called Bread and Breakfast, and she invited me to join the team and said, there is this amazing woman, you can't believe what she can get done. She didn't tell me she also had an amazing daughter. But I have a question for you, and that is, what sort of growth have you witnessed in the last few years since I left? Has it stabilized? Have you been able to extend your umbrella? Have you gotten to the East Coast? Has this phenomenal team been able to percolate through this environment?
I think that, since COVID, we underwent a few changes. We're now basically relying more on telemedicine, and that helps us reach sort of broader section of the population, and also, Virginia, Maryland, DC, but also outside of that area. We are sort of stable, I would say, right now. We're participating actively with other centers in research, and we're doing a lot of clinical work, clinical care. We are interested in reaching the areas that have a little bit lower socioeconomic environment. And in fact, we got a grant from NASPGHAN and Celiac Foundation to explore that, and currently actively working on that. It's outreach to the pediatricians. That's my sort of main way of increasing the awareness of celiac disease and increasing the rates of screening. But we have some other things in the pipeline as well.
If I may, just to follow up, at one stage, the thought was one of the ways to spread was to establish clinics in outlying pediatrician offices. Have you ever attempted that since then? Have you any thoughts of doing that, for instance, on the East Coast, where I know they were not getting good attention?
Yeah, I think that it's definitely worthwhile, idea, but the issue is that we're sort of pulled in multiple directions. Say that again.
You're maxed out, maybe.
Well, you need more people. I think you need more resources to do that, because you have to be multiple places at the same time.
Well, good to see you all. Thank you.
Thank you.
Yes, and I want to echo how we are all so passionate about improving care of celiac disease, and you built amazing programs. So I'm gonna slowly close the webinar, but if you have any other things you would like to add, please go ahead. I'm just gonna try to share a bit differently what I wanted to share. I apologize. Okay. All right. So thank you. We are now on Instagram, so please follow SSCD on Instagram to have the latest news about the research and the activities that are done. Oh, so sorry about that. What is happening? Okay, that should work now. Alrighty. So we will have another webinar on December 10th about the best of NASPGHAN and the single topic symposium that happened. So please register with that link. Most webinars are recorded and posted on the SSCD website for members. I would like to thank the webinar committee that is very active in organizing new webinars, and the SSCD console. As Kate did a very good shout out about joining SSCD, the membership in the SSCD is open to medical, scientific, and allied health professionals. The benefits include webinar, grant, society statements, publication review, mentorship, research development, annual meeting, consult opportunities, the Celiac Disease Unique Recognized Program, and as Kate mentioned, to also be part of the International Society for Celiac Disease. And yes, so I wish everybody a very nice evening.
Thank you.